Okay, so good evening, everybody. Today I'll be talking about cardiopulmonary resuscitation. And the highlights of today's session will be basic life support, advanced cardiac life support, pediatric CPCR, and a few slides about choking. So, talking firstly about basic life support. So, early initiation of BLS has been shown to increase the probability of increased survival in patients experiencing cardiac arrest. And as you all know, that basic life support is it can be done anywhere. It can be inside the hospital. It can be outside the hospital. The two main differentiating features of BLS from ACLS are lack of drugs and equipment in BLS. So it can be done even outside the hospital. So the steps in adult chain of survival should be followed to increasing the odds of surviving a cardiac arrest. And what are the steps? First is the activation of emergency response. Then start performing early CPCR, defibrillation, advanced cardiac life support, post cardiac arrest, and then finally recovery. So this chain of survival can be inside the hospital or outside the hospital. So the main difference inside the hospital is that the first step is early recognition and prevention, because the patient can be under our vigilance, and that is why we can recognize or we can prevent the signs and symptoms of a patient going into cardiac arrest. Then activation of emergency response, then initiation of high quality CPCR immediately, defibrillation if it's a shockable rhythm, post cardiac arrest care after the ROSC is achieved, and finally recovery. But if it's outside hospital, then the sequence of chain of survival is activation of emergency response system, starting high quality CPCR immediately, defibrillation if required, advanced resuscitation, post cardiac arrest, and finally recovery. So, what are the key points in BLS? What constitutes BLS? So, the first step is always ensure scene safety. We should make sure that the patient should be safe, and also we shouldn't injure ourselves, or the rescuer who's performing BLS should always be safe. So, the scene safety should be ensured. The person should be moved out of traffic. If at all the person is drowning, the person is in water or under the waterfall, we should move the person out of it and we should dry the patient. Next is assessment of the person. Shake the person, tap their shoulder hard, talk to them loudly, see whether they are responding, check for breathing. The third step is call for EMS. If two rescue a BLS, so if there are two persons who are performing basic life support, we can ask the second person to call the emergency medical response and get an automated external defibrillator. And if we are alone, we can call and ask for help. But most importantly, we should not forget that we should ask for help on the speaker phone, because we shouldn't waste any time. We should immediately dial the phone. We should put our phone on speaker and we should immediately begin the CPCR, and always call for help without leaving the patient. The fourth step is CPCR, start the chest compressions, and the final step is defibrillate. Once you get the AED paddles, you attach the paddles to the patient, and if it's a shockable rhythm, and then you immediately defibrillate. So these are the key points in BLS. The first one is be safe, ensure the scene safety, ensure the safety of the patient, ensure safety of yourself. Next is proper assessment of the patient, but this assessment of the patient has to be done within 10 seconds, because we don't want to lose time and we want to start our treatment as early as possible. The third one is activation of emergency response system. Fourth one is start immediate CPCR, and the last one is defibrillate if required. So once we want to check the pulse, which we will do in assessment of the patient, we will check the carotid pulse, as carotid artery is a central circulation, but we shouldn't do it more than 10 seconds. Once we start the chest compressions, we always use the heel of one hand on the middle of the chest, on the lower half of the sternum. We put another hand on the top of the first hand. We should make sure that our arms are straight, our elbows are not bending, and the depth of compressions should be around 2 to 2.4 inches, which is around 5 to 6 centimeters. And in between the compressions, we should stop pressing the chest. We should allow the chest to recoil completely, so that the venous return is not obstructed and the cardiac output is maintained. After 30 compressions, we stop the compression. We open the airway by tilting the head and lifting the chin. That is a head tilt, chin lift maneuver. And this maneuver should not be performed in case the patient has a neck injury or is suspected to have a neck injury. In that case, we can use jaw thrust to open the airway. So that is why we have to give a breath after opening the airway. And while giving the breath, we watch the chest rise. our breath will not be adequate if there is no chest rise. So we give two breaths, one each breath over 1 second. So finally, our ratio will be 30:2. So this is, we are talking about BLS, where we do not have drugs and equipment with us, where we are giving 30 chest compressions. After every compression, we are giving the chest some time to recoil so that there's adequate venous return. And once the 30 compressions are done, we give two breaths to the patient, each breath over 1 second. And after giving those two breaths, we again resume the chest compressions immediately. So this is how it's done. In the figure A, it's shown how to check for the carotid pulse. Figure B shows how to place the heel of your one hand over the lower half of your sternum in the middle of your chest, and the other hand should be placed over the first heel. The fingers should be interlocked and the arms should be straight. There should be no bending of the elbows. After 30 compressions are done, we are supposed to open the airway of the patient. We can do it by head tilt and chin lift maneuver. If there is a suspected neck injury, we can perform a jaw thrust to open the airway and give two breaths, each breath over 1 second. This is called as mouth to mask ventilation. This is included in BLS, that if at all we have a mask to support the ventilation or to support the breaths that we are giving, we can give mouth to mask. Otherwise, mouth to mouth breathing is expected. In these figures A, B, and C, we show that AMBU is also included in BLS. So only if, as far as the equipment is concerned, if there is a mask and an AMBU, they are included in the equipment portion of the BLS. Now, if at all it's a two rescuer BLS, if we have an assistant with us, then the first rescuer always starts the CPCR. The second rescuer prepares the automated external defibrillator and applies the AED pads and also gives the breath. So first rescuer always looks after the chest compressions. The second one looks after the AED pads and also gives breath. And after 5 cycles are done, like we discussed before, that one cycle is equivalent to 30 compressions followed by two breaths. So after 5 cycles are done, we switch the roles. So the first rescuer will take position of the second one, will take care of the AED pads and will give two breaths after 30 compressions, and vice versa. And always give high quality CPR, which we will discuss later. So how about the use of AED? So let's talk a bit about it. Automated external defibrillator is a device which recognizes ventricular fibrillation and delivers electric shock at the right time. But before giving the shock, we should always make sure that we are away from the patient, and also the patient is at a safe place, away from electricity, away from water. The patient should always be wiped if the patient is wet. And if the patient has a PPM, that is a permanent pacemaker implanted, or automated implantable cardioverter defibrillator implanted, which we can see as a bulge over the chest, we should place the pads as close to the correct position, but not directly over the PPM. And we should shock the patient if at all defibrillation is required, but we should make sure that the paddles are not over the device. So these are the general steps of AED. First is retrieve the AED, open the case, we turn it on, we expose the person's chest. We have discussed that if the chest is wet, we dry the chest, we remove any medication patches if we can see any. We take the AED pads, we peel off the backing, apply one pad over upper right chest above the breast, and apply the second pad on the lower left chest below the armpit. Before shocking, always make sure that you have moved away from the person is at a safe place. The AED will analyze the rhythm before it asks you to deliver a shock, and once it reads shock, we press and hold the shock button until the AED delivers its shock. And once the shock is delivered, we immediately resume the CPCR without looking for the rhythm, and after 2 minutes, that is after 5 cycles of compression and ventilation are done, we recheck the rhythm. So this is the BLS algorithm. We were talking about high quality CPR. So basically, a high quality CPCR means we allow for complete chest recoil between the compressions. We have discussed the reason before. We minimize interruptions between the chest compressions. We assure that the breaths I'm giving or making an adequate chest rise. We shouldn't over ventilate, because the more we ventilate, the more the intrathoracic pressure rises and it decreases the venous return and it compromises the cardiac output. And we always assess for a shockable rhythm as soon as AED is available, and we shock if it is a shockable rhythm. So we first assess the patient. If the patient is unresponsive without any normal breathing, we ask somebody to get the automated external defibrillator. We activate the emergency response system. We look for the pulse of the patient, that is a carotid pulse, and all this should be done within 10 seconds only. If the patient has pulse, but the patient is not breathing or the patient is unresponsive, we should just administer one breath every 5 to 6 seconds. So that makes 10 to 12 breaths every minute. Also, we have to assess the pulse every 2 minutes because the patient may deteriorate and the patient may become pulseless, and we might have to initiate chest compressions. So that is why every 2 minutes the patient has to be assessed. But now, if there is no pulse, we will immediately start chest compressions, 30:2. And if the defibrillator arrives, we have discussed how to use the defibrillator. We will attach the paddles to the patient. If it's a shockable rhythm, we will shock the patient and we will resume the CPCR immediately. And if it is a non-shockable rhythm, we will continue CPCR. So a quick summary for BLS. We quickly start the chain of survival, which can be in hospital or out of hospital. Deliver high quality CPCR. One cycle of CPCR contains 30 compressions followed by 2 breaths, and we should always make sure that the operators are switched after 5 cycles. If no breathing but only pulse is present, then give one breath over 5 to 6 seconds, which makes it up to 10 to 12 breaths per minute. Know when and how to use the AED. Provide rescue breaths, and always make sure that you are working as a proper team. Now, coming to advanced cardiac life support, there are a few points which are included in the ACLS survey. The first one is airway. So remember that ACLS, the biggest difference between BLS and ACLS is presence of or usage of drugs and equipment in ACLS. So first is airway. We monitor and maintain an open airway, like how we were doing in even in BLS. We didn't have any equipment. Mostly we had an ambu or a mask, but then we used head tilt, jaw lift, a head tilt, chin lift, or jaw thrust in order to keep the patent airway. But we need a definitive airway in order to maintain the airway and also to prevent aspiration, because of which we can use either basic airway equipment like oropharyngeal airway and nasopharyngeal airway, or advanced airway equipment like LMA, laryngeal tube, combi tube, or an ET tube. The decision to add an advanced airway must be taken by the provider if it outweighs the risk of pausing the CPCR. But if we decide to secure the airway, that also has to be done within 10 seconds so as to minimize interruptions in the chest compressions. The second aspect is breathing. Give 100% O2 because in BLS we didn't have oxygen. Now we have got oxygen. We give 100% of O2. We should target an SpO2 more than 94%. But if all EtCO2 is less than 10 mmHg after 20 minutes of CPCR for an intubated patient, then we may consider stopping resuscitation attempts. For maintaining a patent airway, we should also perform suctioning when there are copious secretions, blood, or vomit. But always remember that when we are performing suctioning, we are interrupting the oxygen supply, so that may cause desaturation. So perform suctioning only if needed. The third one is circulation. Obtain an IV access or an intraosseous access if an IV access is not easily available. Monitor the BP by NIBP or arterial blood pressure. Give rhythm specific medications and give fluids when appropriate. And next is defibrillation. Defibrillate if it's a shockable rhythm and try to identify the cause. So the key points of AED are: assure oxygen is not flowing across the patient's chest when delivering a shock, because we should make sure that while anytime when we are delivering a shock, the patient should be away from electricity, the patient should be away from water as well as from oxygen. Do not stop chest compressions for more than 10 seconds when assessing the rhythm. Stay clear of the patient when delivering the shock. Assess pulse after the first 2 minutes of CPCR. And we have already discussed that if the EtCO2 is less than 10 mmHg even after 20 minutes of CPCR, we may consider adding a vasopressor or we may terminate our resuscitation attempts. Now, what are the rhythms which lead to cardiac arrest? There are 4 main rhythms which cause cardiac arrest, out of which 2 are shockable and 2 are non-shockable. The shockable ones always carry a better prognosis as compared with the non-shockable rhythms. So the shockable rhythms are pulseless ventricular tachycardia. You can see in the ECG, these waveforms are quite, QRS complexes are monomorphic, RR intervals are regular. You cannot make out any P waves, and that is why you cannot measure the PR intervals, but the QRS complex is wide and bizarre. The second shockable rhythm is ventricular fibrillation. It's a complete chaotic, disorganized rhythm. You can see QRS complex, but it's absolutely varying in its size and shape. Like pulseless ventricular tachycardia, there are no P waves, no PR intervals can be seen. The 2 other rhythms, which are non-shockable, The first one is pulseless electrical activity. And this pulseless electrical activity can include any rhythm except ventricular tachycardia, ventricular fibrillation, or cardiac systole. Even a normal sinus rhythm seen on the monitor can be a pulseless electrical activity if the patient doesn't have any pulse, if the patient is not breathing, and if the patient is unresponsive. So, still we can consider it as cardiac arrest, even a normal sinus rhythm which is being portrayed on the monitor. And last is cardiac systole, which is again a non-shockable rhythm, and rhythm is merely a flat line. We cannot distinguish any waves. There is no rate. So ACLS rhythm for adults, we first start CPCR, we start oxygen, we attach the defibrillator, we see whether the rhythm is shockable or not. If the rhythm is shockable, that means it could be either ventricular fibrillation or pulseless ventricular tachycardia. Our first step will be to shock. Don't assess the rhythm. Start immediate CPCR for 2 minutes. Meanwhile, take an intravenous access or an intraosseous access. After 2 minutes, again check for the rhythm. If the rhythm is still shockable, give shock again. Continue CPCR for 2 minutes. Give epinephrine every 3 to 5 minutes. Consider advanced airway and capnography. Again, after 2 minutes, we'll check for the rhythm. If again it is shockable, then we give shock. After 2 minutes, we again check for the rhythm. Amiodarone and lignocaine can be considered in the refractory cases, and meanwhile, we keep treating the reversible causes also. If at all the rhythm is not shockable, it could be either a systole or pulseless electrical activity. Our first step will be epinephrine before starting the CPCR. So keep it in mind that depending upon the rhythm, before initiating CPCR, our first step will be either shock or it will be epinephrine, and then we start CPCR immediately. So if it's a non-shockable rhythm, we have given epinephrine, we restarted the CPCR for 2 minutes. Meanwhile, we have secured an intravenous or intraosseous access because we need to give drugs. Consider advanced airway. We again, after 2 minutes, we check for the rhythm. If it is shockable, then we carry on these steps. We give a shock, and again, the same cycle is repeated. If there is a return of spontaneous circulation, we go to post cardiac arrest care, which we'll be talking about later. And if there is no rhythm at all, then for around 20 minutes, around 30 minutes, we may or may not consider terminating our attempts. So high quality CPCR, we have already discussed that we should push hard and fast. Our depth of compression should be 2 to 2.4 centimeters. I'm sorry, that is inches, which is around 5 to 6 centimeters. And the rate of compression is 100 to 120 per minute. We should allow the chest to recoil, minimize interruptions, do not overventilate. If there is no advanced airway, 30:2 compression ventilation ratio should be there, and attempt to improve the CPR quality if the EtCO2 is less than 10 mm of mercury. Shock quality, so it can be either a biphasic shock or monophasic shock, but nowadays we use only biphasic shocks because they cause less burning, they use lesser amounts of energy, and they are lesser traumatic as compared to monophasic shocks. They are also more effective. We always tend to follow the manufacturer's recommendation for the initial shocks. It can be ranging from 120 to 200 joules. If we are not sure about how much the range is, we can use the highest energy which is available. If we start with a lower energy, then the subsequent doses can be increased. Now, what do we mean by return of spontaneous circulation? The patient's pulse and the blood pressure have written. An abrupt rise of EtCO2 of more than 40 mmHg is a very reliable sign of ROSC. And if there is an arterial line in C2, if there are spontaneous arterial pulse waves which are seen on the monitor, that's also a sign of ROSC. Advanced airway, we have already spoken about it, that we can either insert an LMA or an ET tube. ET tube is a gold standard because it prevents aspiration. And capnography is extremely important because it helps us to confirm the endotracheal tube placement and also to monitor the quality of CPR. Like we discussed, that if the EtCO2 is less than 10 mmHg, that indicates that we need to improve the quality of CPCR. And if there's an abrupt increase in EtCO2 of more than 40 mmHg, that's a very reliable sign of ROSC. So that's how the capnography helps. And as far as the drugs are concerned, we spoke that if it's a non-shockable rhythm, always start with a drug first before starting CPCR. And we always give epinephrine. Adrenaline is the drug of choice. And the dose is 1 mg, either intravenously or intraosseously. It's administered as soon as possible, and then we keep repeating it after every 3 to 5 minutes. In the refractory cases, we can also use amiodarone or lignocaine. The dose of amiodarone in cardiac arrest is 300 mg bolus, followed by 150 mg as a second dose. Lignocaine can be used as 1 to 1.5 mg per kg as a first dose, and second dose is zero point 0.5 to 0.75 mg per kg. Endotracheal instillation of drugs is not considered to be accurate, because initially it was said that if we want to use a drug endotracheally, if you do not have an IV or IO access, then the absorption of the drug given endotracheally, it is a very unpredictable kind of an absorption. So that is why the doses that were used were 5 times the dose that are given through the intravenous or intraosseous route. But nowadays it's not recommended, because the absorption is quite unpredictable, so we are not sure how much it will affect. So that is why main two routes which are important in cardiac arrest are intravenous and intraosseous. The reversible causes of cardiac arrest, the 5Hs and 5Ts, is a very interesting thing and very common question that are asked in exams. So 5Hs is hypoxia, hypovolemia, H plus ion, which means acidosis, hypothermia, and hyper or hypokalemia. And the 5Ts are tamponade, which can be cardiac, then tension pneumothorax, toxins, thrombosis, which can be either pulmonary or coronary. Now, post cardiac arrest care. So, if the patient shows signs of return of spontaneous circulation, um, we talked about it, like if there is a pulse wave and if the blood pressure has risen, and if there's an abrupt rise of VTCO2 more than 40 mmHg, we take it as ROSA. Now, once the ROSC is done, we manage the airway. If the endotracheal tube is not in place, we secure the airway of the patient. The respiratory parameters are managed as follows. Like we start with a respiratory rate of 10 breaths per minute, like how we discussed that we do not overventilate in order to prevent the decrease in venous rhythm. So we start it at 10 breaths per minute. The target SpO2 in post cardiac arrest care is 92 to 98%. The PaCO2 is 35 to 45 millimeters of mercury. The systolic blood pressure is maintained more than 90 mmHg, and the mean arterial blood pressure target is more than 65 mmHg. This is done by means of using bolus, IV bolus, or 1 to 2 liters of normal saline or lactated drinkers. And also drugs can be used like epinephrine, dopamine, and norepinephrine infusions. Epinephrine and norepinephrine can be used in the dose of 0.1 to 0.5 mics per kg per minute, and dopamine can be used in the dose of 5 to 10 mics per kg per minute. So these are the drugs and the IV boluses which can be used to maintain these hemodynamic parameters and the respiratory parameters in order to decrease the venous rhythm and decrease the intrathoracic pressure, leading to decrease in venous rhythm. We obtain a 12-lead ECG of the patient because we want to rule out acute coronary syndrome, or we want to rule out whether the patient needs any mechanical circulatory support also. We see whether the patient is following commands. Now, if the patient is following commands, we go for the critical care management as per the clinical situation of the patient. But if the patient is not following commands, we have to go for targeted hypothermia, targeted temperature management. We go for CT brain, EEG monitoring. So for targeted temperature monitoring, if the patient is not following commands, we started at 32 to 36 degrees Celsius for 24 hours by using a cooling device. And other critical care management as per the patient is we continuously monitor the core temperature, we maintain normoxia, normocapnia, and we provide continuous EEG monitoring and most importantly, lung protective ventilation. So targeted temperature management if the patient is not obeying commands, and other critical care management will be as per the critical condition of the patient. Now, talking a bit about the acute coronary syndrome. So, what clinical conditions are included in ACS? The first one is unstable angina. Unstable angina, if you do an ECG of the patient, there will be no STT changes, but the patient will complain of severe chest pain at rest. The second one is non-ST segment elevated MI, where you will not have ST segment elevation. There can be ST segment depression, but the cardiac enzymes will also be increased. And the last one is ST segment elevated myocardial infarction. So these three clinical conditions are a part of ACS. They make acute coronary syndrome. So if a patient, so it could be either a patient in the post cardiac arrest care, or we could be in the ICU and a patient could come to us with acute chest pain and we could be suspecting that the patient is having acute coronary syndrome. So how we will manage this patient? The first is we give oxygen. If the patient is already intubated, we continue ventilation. But if the patient is awake, conscious, oriented, we give oxygen 4 liters per minute through the nasal cannula. We give aspirin 160 to 325 mg. We ask the patient to swallow this drug, to chew this drug, and make sure that we avoid a coated aspirin drug because it will take some time to get reabsorbed, and we want a drug with an immediate action. So that is why we will avoid coated acetylsalicylic acid. Next is nitroglycerin because it's a coronary vasodilator and it also helps to alleviate the chest pain. So we give it as a sublingual spray, zero point 0.3 to zero point 0.4 mg. We give 2 doses of it at 3 to 5 minutes interval, but we should make sure that the patient's systolic blood pressure is not less than 90 mmHg because it's a venodilator, it decreases the preload, it causes hypotension. And also the most important history that we need to take of the patient is whether the patient has been on any phosphodiesterase inhibitors like Viagra, specifically within the last 24 hours.